Okay, welcome back to our discussion. I'm Carla Sáenz. I'm Regional Bioethics Advisor at the Pan American Health Organization, and I'm also a member of the Workshop Planning Committee. And I'm going to be moderating this session with my colleague, Ken Kessler, that you've met earlier today. And in this session, we're going to move to the global arena. We're going to be discussing global aspects of the COVID-19 response that enable a successful coordination, and we want to see what worked at a global scale and what could have been done better. And just like in the previous session, we'll be talking about the production of research, but also about the equitable access of the research results. So we're going to start with a plenary presentation by Dr. Peter Hotez, and then we're going to have a panel, and then we're going to bring in the colleagues from the previous panel, so we'll have a big discussion. And, well, I want to introduce Dr. Peter Hotez, although he doesn't need much of an introduction. He's a professor of pediatric and molecular virology at Baylor College of Medicine, where he's also the Texas Children's Hospital Chair in Tropical Pediatrics. He's a well-known vaccine scientist who has co-led the development of vaccines for neglected tropical diseases and a COVID-19 vaccine technology that has led to the production of COVID-19 vaccines in India and Indonesia and widespread administration of this vaccine. So welcome, Peter. Thanks for joining us virtually, and over to you.
Well, thanks so much for having me, and apologies for not being there in person. I had a commitment in New York, so I'm actually talking to you from my hotel room in New York. But it's great to even be part of this virtually. But I'm going to give kind of an overview of some of the big picture issues that I see in vaccine equity. And one of the not so obvious things that I want to talk about is how now vaccine hesitancy may be almost as important as vaccine equity in terms of vaccine accessibility, and give you my thoughts on that as well. So if I could go to, we'll call this slide number 1, if I go to slide number 2, which is, in addition to being an academic and professor and dean at Baylor, I co-direct with my science partner for the last 20 years, Dr. Mary Elena Patazzi, this very interesting Center for Vaccine Development called the Texas Children's Hospital Center for Vaccine Development. That's a nonprofit product development partnership that develops primarily parasitic disease vaccines for schistosomiasis and hookworm and Chagas disease and leishmaniasis, something that I've been doing since I was an MD PhD in New York, it's in the 1980s. And then about 10 years ago, we actually started making coronavirus vaccines because they were orphaned just like our vaccines for parasitic diseases are. So we started making SARS and MERS vaccines. And then when the COVID-19 sequence hit in January 2020, we pivoted and used our same technology approach to make a COVID vaccine. Next slide, please, number 3. And we sometimes call these vaccines anti-poverty vaccines, less so COVID, but more the parasitic disease vaccines, because they represent diseases that not only occur in the setting of poverty, but actually cause poverty because of their chronic and debilitating effects on child development, worker productivity, reproductive health, especially women's reproductive health. And I first started writing about these conditions in my first book called Forgotten People, Forgotten Diseases. Next slide, please. So an example is our vaccines for parasitic worm infections, for hookworm and schistosomiasis. And just call your attention to the map there, which if you were thinking about creating a biotech or a pharma company, not necessarily the map you want in your business plan, since most of the commercial interest is based on North America and Europe and Japan. But we are very interested in pioneering not only the science behind behind these parasitic disease vaccines, but also creating a sustainable business model for diseases that are especially of regional importance in places like sub-Saharan Africa, like schistosomiasis and hookworm infection. And both vaccines are now in phase 2 trials in Uganda, Gabon, and Brazil. On the next slide, The problem of schistosomiasis is particularly important for female reproductive health. Female genital schistosomiasis is caused by when the spine-shaped eggs get in the cervix, uterus, and lower genital tract and cause pain and bleeding in 40 million girls and women on the African continent. Also, there's a lot of social stigma attached to it, and marital discord and depression. Oftentimes it peaks during adolescent years, so teenage girls get falsely accused of being sexually promiscuous, when in fact they by the community health workers, when in fact they get it by standing in water contaminated with the larval stages of the parasite. It's also a major cofactor in Africa's AIDS epidemic, a 2 to 3-fold increase in risk in acquiring HIV/AIDS. So we're making that vaccine that's now in phase 2 clinical trials. Next slide. And our approach is somewhat unusual in that we're specifically set up to be compatible with vaccine producers in low and middle income countries. So around 40 of them have grouped together and call themselves the Developing Country Vaccine Manufacturers Network. And one of the most common core technologies they use is microbial fermentation in yeast. That is, they make recombinant proteins in yeast primarily to make the recombinant hepatitis B vaccine. So the recombinant hepatitis B vaccine made in yeast is one of the most widely produced vaccines directly in low and middle income countries. And countries to the left, for instance, Bangladesh, China, India, Indonesia, Thailand, Vietnam, Argentina, Brazil, Cuba, make their own recombinant hepatitis B vaccine. So our thinking is if we're going to plug and play into low and middle income country vaccine producers, that's a pretty good technology to try to adopt for making our parasitic disease vaccines. And ultimately, we did this for SARS and MERS and COVID. Next slide. So this is what the world looked like in terms of COVID vaccinations in 2021, early 2021, where we were getting frantic phone calls from South Asia, Southeast Asia, African countries, because they realized mRNA vaccines were not coming anytime soon, and could we help? And so this is a bubble map of where places are unvaccinated. And the world paid a heavy price for this, not only because of the humanitarian tragedy of not providing access to vaccines, but if you remember, the Delta variant arose out of an unvaccinated population out of India, and the Omicron and its subvariants out of an unvaccinated population on the African continent. And so the world paid for that vaccine inequality. And what we did on the next slide was to say, we're going to apply our microbial fermentation and yeast recombinant protein approach that was successful for SARS and MERS, do this for COVID-19. And we transferred the technology, our production cell bank and technical know-how for scale up to vaccine producers in low and middle income countries. And the one that got the furthest, although by no means the only one, was a vaccine producer based in India known as Biological E. They're one of the big vaccine producers, transferred the technology, and they scaled it up to make Corbevax, that's the name of the vaccine, locally made, and now that's reached 75 million children in India, and as well as another 10 to 15 million adult boosters. So we're going to hit the 100 million dose administered mark. And so it provided proof of concept that while the multinational pharma companies do a lot of important work and provide vaccines for the Gavi Alliance, it's not the only way, and that there's an alternative path by partnering directly with low and middle income country vaccine producers with new technologies and brand new vaccines that were not being made previously. On the next slide. I won't go too much into the science, just to tell you the kinds of things that we do. We had found for SARS and MERS that if you, that red bar on the upper left is an N-terminal asparagine. If you express the protein without an N-terminal asparagine, you reduce glycosylation, which interferes with immune responses. In the green there's an odd number of cysteines. So if you change one of the cysteines to an alanine, what you can do is prevent intermolecular disulfide bond aggregation. And the point is we put all of that in the public domain. So you can follow every step we use to make our coronavirus vaccines or all our vaccines by downloading papers from the National Library of Medicine PubMed database. And so our thinking is that, anybody should have access to the technology. We make it so you don't even have to contact us. You could just reproduce it, but we make it easier by providing the production cell bank and helping the organization with the early scale up. On the next slide. So we do the scale up in our labs, and we invite their scientists to come into our lab, or either virtually or actually physically be there. And then the next slide. We partnered with the Emory University Non-Human Primate Center to show that the vaccine stopped virus replication in the lungs and other tissues, and there was no lung pathology. So it really looked like an exciting vaccine. And that was the good news, but the frantic news on the next slide was we were getting these desperate calls from ministers of health and ministers of science, throughout 2020 and most of 2021. So we wound up having to do our own version of Texas vaccine diplomacy and provide the production cell bank and the technical know-how. We ultimately did this with four vaccine producers in India that made Corbevax, Indonesia that made Indavac, Bangladesh, and with a company known as Incepta, and in Botswana in southern Africa. And so it was a very tense time because my morning, what it's like to do business with Asia, early morning Zoom calls at 4 or 5 a.m. And then of course I was going late into the night talking to Don Lemon and Lawrence O'Donnell. And so I didn't sleep for 3 years, but we did get some things done. On the next slide. So at that point, we transferred the technology, they own it, they work out with the World Health Organization and their own national regulatory authority in India, that's the DCGI, how to do the clinical trials and what they want to look for. On the next slide. And in this case, the DCGI, the Indian Regulatory Authority, asked them to do a superiority study with the only other vaccine made in India, which is Covishield, the Oxford AstraZeneca vaccine made by Serum Institute of India, and it was shown as superior in terms of levels of virus neutralizing antibody T cell responses, holding up to the variants, durability of protection. And on the next slide, it was ultimately shown to be equally safe and immunogenic in children. And then it rolled out, next slide, to initially adolescents, 12 to 14-year-olds on March 15th, 2022. And now it's reached 75 million adolescents, and as well as now it's approved as an adult booster. And now we're making the BA.5 version of this to provide additional boosting both for kids and adults. Next slide. We did the same with Indonesia. One of the interesting spins on this was because it's microbial fermentation in yeast is a vegan technology, the Indian government worked out with the clergy that it could be certified as a halal vaccine for Muslim majority countries. So that was done as well. And now this is being scaled to 120 million doses for Muslim majority countries, including those outside of Indonesia. And on the next slide, we're now looking at how to do this for the BA.5 variant. We've made it. It looks really good in terms of immunogenicity and cross protection against the new variants of concern, possibly including the Scrabble variants, as I call them, like XBB and BQ1 and BQ1.1. We also think that this is a booster would really help other countries that has been vaccinating with vaccines that may not be giving the best level of protective immunity. I'm thinking, for example, China. This could really help China, which is in this horrible dilemma currently, and this might make a very effective booster vaccine for them. Next slide. So now the world is starting to think about what happens if and when we get to the other side of COVID-19, and the World Health Organization has put out this a very important immunization agenda 2030 to look at how they proceed over the next 10 years. And unfortunately, it's starting out in a pretty rocky way. On the next slide. The problem is this: we've already seen a big downturn in our ability to vaccinate the world's children. After 2 decades of progress with the formation of the Gavi Alliance, we're starting to see now it going the other way, that we're now losing ground. So for the first time, the number of kids immunized globally has declined from 86% to 81%. It may not sound like a big decline, but it's the first time it's gone in the wrong direction. And now we have a new rise in the number of fully unvaccinated kids. And part of that, no doubt, is the social disruption from the COVID pandemic. But the other piece to this is a new rise in both US and global anti-vaccine activism. And my premise is there's been a tear in the matrix and something new and ominous has happened. And so that's me in the monk painting over there. I'm quite alarmed about what has happened with the anti-vaccine movement coming off the rails as it has. So what I want to do in the next slide is kind of quickly explain all of this. This is my last book called Preventing the Next Pandemic, and it looks at some of the big social drivers bringing back disease together with climate change. And it turns out anti-science may be one of the most important of all in a very negative way. Next slide. So I want to quickly end by taking you through the 3 versions of the anti-vaccine empire, how it began more than 20 years ago as version 1.0, with false assertions that vaccines cause autism, how it's become more of a political movement over the last 7, 8 years as version 2.0, and now how it's globalizing and actually driving down all vaccination rates. And this is going to be a formidable task for us. That vaccine hesitancy has become a new version of vaccine inequality. So let me briefly, I want to end by quickly taking you version 1.0, 2.0, 3.0, because there's some non-obvious things to talk about. So let's go to version 1.0 first. Next slide. Even within that, there was a lot of nuance and then a lot of switching up or moving the goalposts. By that, I mean, an assertion was made that a certain vaccine caused autism. The scientific community would debunk it, respond to it, and then they would switch it up. So it began on the left with false claims that the MMR, measles, mumps, rubella vaccine caused autism. That's what came out of the Lancet paper in 1998 that was eventually retracted, and the scientific community was able to show that kids who got the MMR vaccine were no more likely to acquire autism than kids who didn't get the vaccine. And similarly, kids on the autism spectrum were no more likely to have gotten MMR than kids not on the autism spectrum. That should have been the end of it. But then anti-vaccine groups started monetizing the internet, getting stronger, and they kept up switching up what the assertion was. Then it switched to thimerosal preservative that used to be in vaccines, spacing of vaccines too close together, alum in vaccines. And for a while, they were focusing on the HPV vaccines for cervical cancer and other cancers, claiming it caused infertility or autoimmunity. And if that sounds familiar for COVID-19 vaccines, that's where they got it from. They just copy pasted the false assertion onto COVID-19 vaccines. Next slide. And I got involved in this because on the upper left, I have 4 adult kids, including Rachel, has autism and intellectual disabilities, and wrote a book with a straightforward title, Vaccines Did Not Cause Rachel's Autism, which went into the science showing there's no link, but also what autism is and how it begins in early fetal brain development through the action of autism genes and epigenetics. We did whole exome genomic sequencing on Rachel and my wife Ann and I, and we were able to identify one of Rachel's autism gene, which is involved in neuronal communication. That was actually published. So there's about 100 autism genes. Most of them are involved in neuronal communication. Many, like Rachel's, a neuronal cytoskeleton gene, which makes a lot of sense. And I think all of that took some of the wind out of the sails of anti-vaccine groups around autism assertions, but they needed to regroup. That OG in the bottom right there means that's the moniker they gave me. They started calling me the OG villain, which I had to look up what it means. So the original gangster villain. Next slide. And the way they regrouped is kind of interesting, not in a way that I would have predicted. And they took on version 2.0, and it started in the 2010s. So many kids in Southern California were not vaccinated because of parents were fearful about autism, that not surprisingly, there was a large measles epidemic. That's often the first breakthrough you see when vaccination rates go down. And the California legislature responded appropriately by shutting down vaccine exemptions. And I supported that, but it also led to a backlash around this concept of health freedom or medical freedom. And they found a new fellow traveler or partner in the form of the Republican Tea Party, of all things. And this really accelerated in Texas on the next slide, where they started getting PAC money. So this became a political movement on the far right. And under this banner of health freedom, more than 100,000, almost 100,000 kids stopped getting one or more of their vaccines. And this didn't even account for any of the 300,000 homeschooled kids. And what you had was your own anti-vaccine PAC that was actually helping candidates run on anti-vaccine platforms. So it took this very dark turn in the state of Texas. And that's what's come off the rails now in this time of COVID-19 under this expansion of health freedom or medical freedom, really with Texas where I'm based at its home. And the next slide. And anti-vaccine activists started coming to Texas, and this is an event in front of the Texas State Capitol, and doing things like misappropriating the Holocaust, comparing vaccines to the Holocaust, really offensive stuff, wearing phony yellow Jewish stars with the word Novax written in Hebrew letters. And then you started to see a fair amount of anti-Semitism go along with that. And the fact that I'm a Jewish scientist was not lost on me, that there was that other dark element to it as well. And so on the next slide, this is what's happened now during COVID-19. This is a paper that I just published in Public Library of Science, and I wrote it called The Great Texas COVID Tragedy. And I'll finish up and I'll show you what this is. Next slide. And what I'm showing you is the peaks of deaths from COVID-19 in the state of Texas across the pandemic. And so it starts in 2020 with the original wave, and there's a small bump. That's when the virus first came into New York. Then the first big wave was the original lineage in the summer of 2020. It really decimated Texas. And then in the winter of 2021 was the alpha wave. Then that green arrow that I'll talk about in a minute. Then came the big delta wave of deaths, and then the Omicron waves of deaths. And that green arrow indicates May 1, 2021. That's the date that the Biden administration announced that anyone who wanted to get a COVID vaccine could get a COVID vaccine, and vaccines were widely available. And similar dates in Australia and Canada pretty much signaled the end of large numbers of deaths. But in Texas, they continued unabated because so many Texans refused to get vaccinated because under this banner of health freedom, medical freedom. In all, I estimate almost half of the 90,000 deaths in Texas were unnecessary because they occurred in the Delta and early Omicron waves. Vaccines were widely available, and 40,000 Texans needlessly lost their lives because they refused to get a COVID vaccine. On the next slide. And this was also borne out nationally, mostly in Texas and other southern states, and up in the almost up in the mountain west as well. So all in all, 200,000 Americans needlessly lost their lives because they refused a vaccine after they became widely available. And now we know why this has happened. And it's a very hard thing to talk about, but I think, I don't even figured out a way to talk about it other than to talk about it on the next slide. This is an analysis done by Charles Gaba, the health analyst, and it's been reproduced by the New York Times, National Public Radio, Axios, the Kaiser Family Foundation, Pew Research Center. So if you look at that peak on the right, almost all of the deaths were due to people who refused a vaccine in red conservative states, and the redder the county, the lower the vaccination rate, the higher the death rate. And we now know why this is. It was the CPAC conference in Dallas in 2021, the Conference of Conservatives. We all heard it. First, they're going to vaccinate you, then you're going to take away your guns and your Bibles. or the representative from Georgia compared me and others, those who vaccinate as medical brown shirts using Nazi paramilitary analogies. And then every night on Fox News, the two nighttime Fox News anchors, Tucker Carlson and Laura Ingraham, this has been documented now by Media Matters, a media watchdog group, as well as a social science research group at ETH Zurich, which is the big federal university of technology in Switzerland, like the MIT of Europe, has documented this, that it was Fox News that filled up their programming with anti-vaccine content, falsely discrediting the effectiveness and safety of vaccinations. They're saying it was a control plot. And people bought into it in red conservative states and ultimately paid for it with their lives. They were victims of anti-vaccine, anti-science aggression. And we can talk about it at the discussion, but the point is, so far, no one's been willing to talk about this in an open way from the health sector, or at least from Health and Human Services. It's all focusing mostly on the social media companies, but not really addressing those who are generating the content. And now this is happening globally. So in the last slide, this is a paper that I just came out in Nature Reviews Immunology I wrote, where you're now finding that same anti-vaccine content from the US and the political right being exported to the African continent, to low and middle income countries in Africa. You're seeing the Fauci memes, you're seeing the same statements from Fox News anchors and members of the House Freedom Caucus and the US Congress. And it's the hardest thing that I've ever had to talk about, because all of my training, and all of our training as physicians or scientists says we don't talk about Republicans or Democrats or liberals or conservatives. But what do you do when the aggression is so clearly coming along a partisan divide? And how we manage this is something that I think the health sector doesn't quite know what to do at this point. And therefore, we have to bring in experts from political science and social science to really kind of help us sort this through. So I'll stop there, and I look forward to a robust discussion. Thank you again for inviting me.
Thank you so much, Peter. It's been great to reflect that in order to prepare for a future emergency, we do not only need to do the research, we need to prepare to use the results of that research. So I'm going to present the members of our panel now, one by one, and they'll give their remarks in 5 minutes. And I want to invite you all to reflect also in the discussion, not only about the successful research stories, but also about those research efforts that didn't come to fruition, that were so common in low and middle income countries. We know there's been a lot of energy used in very little trials that really were not capable of yielding any knowledge. So I'm going to start by introducing James Anderson, who's the Executive Director of Global Health at the International Federation of Pharmaceutical Manufacturers and Associations, where he leads the work on global health priorities. Welcome.
Thanks very much. A real pleasure to be here with you virtually. I note that being on the global panel means that most of us are virtual. I'm coming to you from London, where it is fairly late in the evening, but very pleased to be with you. In contrast to the previous panel, which was focused more domestically, where everyone, it seems, more or less was there in person. So that's globalization. All right, so briefly, I don't have slides. What I want to talk about is the lessons that the pharmaceutical industry that I represent have learned and are learning through this incredibly concentrated period of pandemic time that we have been living and are still living, in fact. We have published our lessons, as many others have, but I do think it's absolutely critical as we, as a global society, now start to build the new infrastructure to be better prepared against future pandemics, that we do take the time to properly look at what happened in the last couple of years. Both, as has just been said, what worked well, because I think there are many things that do work well, and we should make sure to build on those and not to put them at risk or at jeopardy. But then, of course, we absolutely need to recognize the things that didn't go well. And there are, again, a number of very important areas there. The other introductory point I want to make is around the need for speed, because during pandemics and outbreaks, I think it's clear to everyone that the faster we can respond, and that means the quicker that innovative and effective and safe vaccines, treatments, diagnostics, and other interventions can be developed and delivered, the better, right? That gives us the maximum chance to minimize the outbreak and certainly avoid, or hopefully avoid future truly global pandemics like we're battling now. So to that end, the industry is very pleased to support the 100-day mission that was been proposed initially by CEPI, but very much by the G7 governments as well. We continue to work with that group. It's an ambitious stretch target, but we believe one that we should be pursuing together. So three other lessons then that came out of that are connected to this concept of speed. First of all, pathogen sharing. Clearly, in an emerging outbreak, until the pathogen is available or its genetic data, research can't really get going. But as soon as it is widely available, then research everywhere should be able to kick off and proceed. What we see currently is that although with SARS-CoV-2, the sequences were made available publicly quite fast, there are questions about whether it could have been faster initially in China. And then certainly as the variants have progressed, again, time has been lost to some extent, although it's been pretty good. So we should build on GSAID, a public database that publish most of those sequences. And we should avoid getting tangled up in overly bureaucratic systems and national legislation, often that comes underneath the Nagoya Protocol. We can talk about that more if needed. Secondly, collaborations have been absolutely critical. We've seen collaborations of all sorts, unprecedented in scale and scope, between public sector, private sector, big companies, competitors collaborating together, big companies and small companies. We've counted over 400 manufacturing and production agreements for COVID vaccines alone, and over 150 for therapeutics. And then finally, where we absolutely need to do more is on the equitable distribution and access to these treatments. That clearly didn't work well at all during COVID. And so what we've done to get collectively as an industry is come together and make a proposal, a holistic proposal. We call it the Berlin Declaration because that's where it was agreed to by all the CEOs of the major companies. It has subsequently been supported formally by the DCVMN, the Developing Country Vaccine Network that Peter just referred to, as well as the biotech industry. So the goal is to make sure that the priority populations around the world are given first access to the vaccines, therapeutics, and diagnostics as they are produced in real time during future pandemics. That's how we believe the speed can be actually delivered. And unless that a delivery on the ground happens, then we will be failing again in the future. So those are my three main areas. I'd be happy to talk in more detail about any of them during the discussion, but recognize 5 minutes goes by very quickly, so I will stop there.
Thank you very much, James. Now I'm going to introduce Glenda Gray, who's also joining us virtually. She's the president and CEO of the South African Medical Research Council, and she also is the director of international programs for the HIV Vaccine Trials Network, a transnational collaboration for development of HIV/AIDS prevention vaccines. Thank you, Glenda.
Thanks very much. I speak as fast as Mike Cohen, but in an English that many of you may not understand. So hopefully I'll try and slow down so you can understand my English. So I'm going to talk to you from a perspective of medical research and as a leader of a research council in a low middle income country setting. And I have 7 lessons that I learned that we must move forward for future pandemic preparedness. My first lesson was understanding the importance of surveillance. So when COVID-19 started to increase, in South Africa, we were very worried about our HIV and TB population. We have the largest HIV population in the world, and we have a huge burden of TB. So we didn't know what the natural history of COVID was going to be. And so in terms of surveillance, we immediately ring-fenced money to look at the long-term follow-up of the natural history of COVID. And so there are a couple of importance of surveillance. One was our genomic surveillance. So we had invested a lot of money in TB and HIV, trying to understand the genomic resistance of HIV and TB. And so we were able to pivot our resources into genomic surveillance of SARS-CoV-2, which enabled us to identify variants of concern very early. So that was an important message which we need to continue to go forward. The other was excess deaths. So many other African countries did not have enough documentation of excess deaths, and we were the only country in Africa that actually monitor excess deaths. And we showed that over 300,000 South Africans died of COVID, making us one of the countries with one of the highest case fatality rates in the world if we take into account excess deaths. So moving forward, we need to make sure that we invest in vital statistics and are able to manage and monitor excess deaths in our countries. We established the wastewater surveillance, which has been very critical to serve as an early warning system. And at this moment in time, we not only are we looking at SARS-CoV-2, but are monitoring measles and looking at other pathogens in our wastewater. So important to make sure that we continue to invest in wastewater surveillance. Our hospital surveillance was critical because we were able to monitor how our cases differentiated from hospitalization and deaths when Omicron emerged in our country. And understanding our hospital surveillance, we were able to determine the risk factors and predictors of mortality in our country. And so just marking the importance of hospital surveillance. We also were able to, because of our investment in software, it enabled us to automatically look at SARS-CoV-2 variant typing on sequence data. And doing this, we were able to export our Equitable software to 29 countries around the world, and allow 11 countries in Africa used our Equitable software that enable us to identify variants in an automated function. We also learned then that sharing our data that we were getting from surveillance was very important. The next lesson was about our investment in diagnostics. So at the time when COVID-19 emerged, there was a major lockdown. South Africa went into a lockdown. We closed our airports, we closed our borders, and we had no access to PCR. At that stage, PCR was being diverted to high-income countries, and low-income countries had very little access to diagnostics. So we were able to culture SARS-CoV-2 and develop systems to develop our own diagnostics in South Africa. And by being able to culture the virus, we use this for proficiency testing and validation for developing our own platform. And our technology we were able to import to 26 countries, and we were able to use this as a system to evaluate our own diagnostics. So our lesson 2 was to invest in our own local diagnostics to make sure that we now have point of care testing and are able to develop in our own program in that. For lesson 3, we quickly knew that we didn't have the money or the bandwidth to make vaccines and therapeutics. So we partnered very quickly with CoVPN to work in partnership to execute vaccine trials. But given that issue, we now have looked at how to develop our own localization of R&D capabilities to make sure that we are not unable to make vaccines in the future. In terms of further lessons, lesson 4 was the importance of our investment in basic sciences and clinical research. So in collaboration with the NIH and other entities, South Africa has built a good infrastructure on clinical research and laboratory infrastructure. And having this investment enabled us to pivot very rapidly into doing COVID vaccine trials and also being able to do our immunology and neutralization studies. And so just continuing to invest in a low middle income country setting in communicable diseases is important for us going forward. So we will continue the investment in our basic sciences. As I mentioned before, our lack of vaccine capability left us bereft of vaccine access. And moving forward, we are working with the WHO to be an mRNA hub for vaccine technology development, and hopefully we will become a regional player in vaccine development. But obviously, the issues of global procurement and trying to establish a market for African vaccines will be very important going further, and also to ensure that we were able to export our vaccines should we make them in South Africa. In terms of lesson 6, it was very important that we do invest in capacity development. So we do need to build a workforce that's skilled for biomanufacturing. And part of our program going forward in South Africa is to develop this workforce. And we partnered with a lot of people to train our workforce to work in vaccine manufacturing, so that we are able to be a vibrant people in this sector. So that's going to be very important. As lots of people have mentioned before, in terms of lesson 7, is to try and understand the importance of social science and investment in understanding the human toll in a pandemic, the mental health issues, the increase in gender-based violence, the lack of school access to children. We also think it's very important to understand this vaccine hesitancy, because normally in Africa, we've had wide acceptance of vaccines. And so this vaccine hesitancy came as a huge surprise to us. And so we need to work and understand how these kind of ideas perpetrate across the world, and how to redevelop a trust in Western medicine. And so I think these are all important lessons to take forward, and to make sure that when we are developing pandemic preparedness programs, we understand, particularly in low middle income country settings, the things that set us apart, and the things that made us unable to respond in a way that we could have. And so South Africa suffered dearly because of the COVID-19, and we lost a lot of lives. And even though a lot of people think that the African continent didn't suffer and did it escape the COVID pandemic, that is not true for South Africa. We had a lot of comorbidity, maybe our variability in our age range and the various diseases that we have ensured that we were more affected than the rest of the African population, African countries. So thank you very much for that.
Thank you, Glenda. I'm happy In Kyu Young is joining us in person. He's the Director and Global Head of Programs and Innovative Technology at CEPI, which is the Coalition for Epidemic Preparedness Innovation. Thanks.
So thank you very much. And I have to say, I do feel a little bit lonely, or my name tag feels a little bit lonely up there. So I'm glad to represent in person the globe. Next slide, please. So I think we all can be proud of the achievement during the COVID pandemic in terms of the unprecedented speed in which vaccines against COVID were developed. But I think we all also are aware that if we could increase that speed even more, that we would be able to dramatically decrease the number of deaths for any future pandemic. So that led CEPI to develop the 100 Days Mission, which is really a directional mission, if you will, to try to increase the speed of vaccine development response against future outbreaks. What that will require, and I think what's already been said before, is that most of the work has to be done during the preparedness stage, and that really is a huge paradigm shift. It can't be during the urgent situation when you're trying to do response as quickly as you can. Next, please. So CEPI's 100 Days Mission, one of the tenets of it is to try to develop these vaccine libraries. I think Barney Graham was instrumental in developing that concept. But these libraries would be against high-risk virus families that then can be pulled off the shelf, if you will, and adapted to develop vaccines against new threats. So that, at the very least, the vaccines don't have to be developed from scratch. Next slide. And this has been demonstrated, at least in principle, for the COVID pandemic, in which all of the work that was done with MERS and SARS certainly allowed some pivot to developing COVID-19 vaccines in a way that was speedier than what otherwise would have been possible. So what the CEPI 100 Days Mission entails is to try to replicate, but then improve on what occurred during the COVID-19 pandemic with the coronaviruses. Next, please. So making a shift in this thought process really requires not just technology within the vaccines themselves, but also in the structure and the enabling structures that surround it. And so in terms of clinical trials and regulation, what we really want to develop is a situation where a lot of this work has been done in terms of safety on platforms and other vaccines that use these platforms before any outbreak occurs. So there's already this existing pool of data that allows then during the outbreak itself efficacy to be determined by real-world use of the vaccine. So if this paradigm can be used and accepted in an emergency situation where a lot of this is done beforehand on these platforms, then that would speed the development process tremendously. And so that obviously also requires a regulatory mindset that is different from what it traditionally has been. And I think the challenge will be to get that mindset to be acceptable during peacetime after the emergency has subsided. Next, please. And the other big tenet of the 100 Days Mission is that we need to build a vaccine R&D and manufacturing capacity that is global, closer to where outbreaks occur and also closer to where the tools are needed. So CEPI, working with other partners, is seeking to try to develop a global distribution of R&D and M in a network that will allow rapid response and doses to really then go to low and middle income regions. So in this way, this vaccine development and production would take you closer to where these tools are needed. Next, please. So all of this really provides the basis for CEPI's next 5-year strategy, which we call CEPI 2.0, in which our mission is to accelerate the development of vaccine and other biological countermeasures against epidemic and pandemic threats, and importantly, so they can be accessible to all people in need. So it's speed and also global access. Those are the two critical tenets and pillars of CEPI's strategy going forward. So with that, thank you for your attention, and I'll take my seat at the panel.
Thank you, and don't worry, we'll take care of your loneliness by bringing everybody back to the panel after Walter Cott makes his remarks. Walter is currently the special representative of the Secretary General for COVID-19, representing the International Federation of Red Cross and Red Crescent Secretary General in guiding the COVID-19 response. He's also the Enterprise Resource Planning Lead for the IFRC Senior Leadership Team. Thank you for being with us.
Thank you. I hope that you are seeing my screen or my presentation. If not, I will, because I am seeing SEPI screen still. But now it's okay. I will try to share my screen if possible. If not, maybe I can do just the comments from here. Thank you for having me with you today. I am in Geneva now, in long distance. I was unable to attend the meeting for other commitments here in Europe. But really, from our side, I think in summary, we have 4 main messages to share with you in this event. And the presentation is going to be shared with you all maybe later. The IFRC is a network of 15 million volunteers and 700,000 employees in the world. And we are having very clear definition of our strategy. We have a clear focus on people anticipate, respond, and quickly recover from crisis. This is very important part of our job. The other part is making people's life healthy and safe, and dignifying the life, also giving them some opportunities to improve the livelihoods. And also people supported to mobilize resources and create peaceful environments. But during COVID, we were working on something that was very important for us. COVID was a big opportunity to create transformation, to create very clear action. But I think on that sense, we have to really see how to analyze the transformation that we are dealing with. The transformation that we are experiencing is based on the analysis of statistics, but I think in general terms, on this transformation, we are seeing the way to scale up and to speed up all our processes, all our systems inside, and creating more absorption capacity. We are also changing behaviors. We are creating very big advances in change management inside the organization to be more connected with other external actors. We are improving our capacities to deal with the shadowing effect of COVID. You can see now the presentation in the screen. I will go for the next one, please. And just to show you our priorities in general, you can see the priorities in the left side of the screen. But the question here is, we were obliged to focus all our priorities during COVID time, 3 years, in 3 main pillars of response: addressing socioeconomic impact and sustaining health and WASH, and then strengthening the capacity of the national societies as an auxiliary of the countries. Next, please. The next slide is going to show you some idea about our numbers. There is a kind of summary of some of the matter that we did during COVID. The most interesting one for me is maybe the 1.1 billion people that we reach in communication, actions, community engagement, hygiene, promotion activities, and all the things related with WASH and hygiene promotion, including 170 million that we reach on preparedness, and also 130 that we reach on water, sanitation, and hygiene, concrete products in the communities. But despite of that, we know that we have a big debt. We know that we are experiencing the shadowing effect. And the shadowing effect is COVID was shadowing all the multi-marathon of humanitarian problems that we were living in 2020 and 2019, just before COVID. And then Now COVID is victim of Ukraine crisis and other crises. Now COVID is childbed. We need to recognize that still in the world, we have many countries, more than 90, that are below 50% vaccination. Next, please. The next slide is just to show some idea about our message related with how to learn. Lesson learned during the pandemic. We learned very systematically in three main columns. Number one, we were learning about the behavioral change, the conduct, the way to create solidarity as an engine of new ways of working at local level, the duty of care and business continuity for the essential workers, especially people that are not recognizing normally in the communities, including health workers, doctors, nurses, and other employees of the systems that are not well recognized normally. We don't need only applause. We need also real support and real integration with the future response. Digital transformation and other things. In the systems level, we also see the very important action in using the virtual connection, the information management, and the technology. We did that, and it was very important during this period of time. And then on the thematic side, many of the colleagues are already mentioning very important matter. I put here some on the list. Livelihoods is still a big problem. Mental health, psychosocial support, we did a lot on that. Systems, capacity, trust, communities, we can improve all this. I will let like that, and then the next slide is going to show you something that is the most important message for today. Next, please. My main message for you today is we are still in debt with the humanity. We are not finishing the job. The situation today is we are closing, let's say, the emergency side of COVID, but we are not closing COVID as a pandemic, as an impact. We have collateral damage from COVID, future damage from COVID, and the accumulative effect of having COVID in the middle of other situations are creating more exclusion, more problems, less capacity to respond. The second point is the transition from the emergency phase to the long-term programs and sustainable support is also very connected with the health access and the health sustainability. We need to really pay big attention to health. Health was the most important action during this period and needs to be continued in the next future. The herd immunity is not there, as I mentioned, it's not there yet. And we will have new waves, new variants, new problems, as many of our predecessors are commenting today. Be solution-oriented is another. We are not solution-oriented. We are not creating networks of solutions, and we are proposing to have joint ventures, humanitarian joint ventures, and pandemic and global crisis playbook and systems to manage it. This is a big debt of the humanity. We need to be really asking to ask the question if we are really ready for the next pandemic or for the next acceleration of the current pandemic. And then the last part is investment is very important. Investment is not about only production. It's about investment in absorption capacity, investment in distribution, investment in action in the very local level. And the last point here is also connected with the learnings. We need to really see if we are really learning and how we are going to use the analysis of the depths that we have to really be able to pay together. Last one, please. The next slide. In the last one, I just want to mention that we have big appreciation for all the effort that you are mentioning today, but it's very important that we recognize that we are not yet at the end of this, and we need to continue working together, creating better avenues to support people that is still living in a very bad environments, in a very risky situation about health, but also about other connections that are related with immunization, with treatments, and with access to the health systems. With that, I will stop and over to you again. Thank you very much.
Thank you, Walter, and my apologies for having confused the order of our colleagues that are based in Geneva. Now we have Daniel Bausch. Dan is the president of the American Society of Tropical Medicine and Hygiene. He's the senior director for emerging threats and global health security at FIND, which is the Global Alliance for Diagnostics. And he's a professor of tropical medicine at the London School of Hygiene and Tropical Medicine. Thank you, Dan.
Thanks, Carla. I'm hoping that you can see my slides. Yeah?
Yes.
Okay, yeah, thanks. I'll come back. My colleagues from CEPI and from South Africa actually gave a good introduction to the 100 Days mission, which is kind of at the crux of this. But from the diagnostic angle, there really were quite a few successes that we could point to. And so 64 days after the declaration of a public health emergency from WHO, we had a PCR assay that was granted emergency use listing from WHO. And then 236 days after that declaration, we had the first rapid diagnostic test. So there are some successes to point to in terms of diagnostics from the COVID pandemic and getting these diagnostic tools ramped up relatively rapidly, but still a lot of challenges and a lot of things that did not go well. So you can see in this slide, it took us a while to the slow access to samples and developing diagnostics. Of course, you need access to the biomaterial, clear product requirements. What is the target product profile that an industry partner is supposed to use in order to make a diagnostic test? Regulatory harmonization was really a problem throughout for diagnostics as well as for vaccines and therapeutics. And so a lot of challenges that really need to be addressed if we're going to do better in the next round. But nevertheless, some opportunities. And so, as I mentioned, the RDTs and PCRs and later on genomic sequence really became very regular things. There's no one in the world, I think, now who doesn't know, even if they don't know what the name is, what a lateral flow assay is. Everybody can say, oh, that's the one where you put the drop on the strip and wait to see which lines show up. And even though they don't know the details of PCR, they know, okay, well, that's the one you go to the hospital or the lab to get. And people are even aware of genomic sequencing, and that's the one that tells you which variant whether the variant is dangerous or not. And so we have an opportunity for a routinization of diagnostics that can really be game-changing. And it is game-changing. We used to think of it really to be like this, that you would go to a hospital or a lab, or at least have to go to your primary care provider whenever you thought about a specific diagnostic test. And really that's changing, that we have all sorts of new things that are coming online. And it's not only the RDTs, but really some very exciting technologies, things that we've been promoting with industry partners and find multiplex assays that for a few dollars actually can get you a respiratory panel of 7 or 8 different pathogens that really can be game changing in some of the technology. And there are other things that we don't have time to go into here, wearables and AI and a lot of things. So really the potential for a sea change. And that brings us back to the 100 days diagnostic or the 100 days mission. And my CEPI colleague talked about from the vaccination standpoint. Fine is one of the leaders working closely with CEPI on the diagnostics part of this. I won't have time to go through this slide, but this is our pathway to accomplish the 100 days mission, and a similar parallel type approach to what you saw from CEPI in developing novel diagnostic platforms and then prototype diagnostic libraries for we're starting with 10 different pathogens. This is something that we work with closely with CEPI and figuring out what those pathogens should be. And the idea here is that we could pivot, even if the next epidemic or pandemic isn't from one of those specific pathogens. If you have a library of things that are relatively close, you could pivot relatively rapidly. But there are a lot of challenges that, and for diagnostics, probably many of the challenges are beyond the technical part of this. The technical part might even be easier. Some of the other challenges that I mentioned in terms of access to biomaterials, some of the technology transfer, harmonization of the regulatory environment, and a lot of other things that we need to address. So it's not only about the science and the technical side. And then you can see the red arrow underneath all of this. And so advocacy for evidence-based policy, equitable access, and universal health coverage is something that really it only works if we advocate for those things. And especially I want to put this pitch in for universal health coverage, because when we talk about diagnostics, therapeutics, vaccines, whatever it may be, a patient who doesn't get seen doesn't have access to any of this. And so it doesn't really matter what tools we have. You can have the best therapeutic, the best diagnostic, the best vaccine, but if someone doesn't have access to care, it's really useless. And so we always need to be advocating for that access and universal health coverage. The other challenge that we have, at least for diagnostics, but I would venture to say it's true for vaccines and therapeutics, because it's just such a fragmented field. And so not necessarily intentionally fragmented, but many, many different partners and doing different things. One of the things that we're exploring here from FINE is a diagnostics alliance concept. This would not be the same as a Gavi or a global fund where everything is sort of channeled through one partner, but nevertheless having a convening power and trying to bring different entities to the table, something that is in this particular case harder for WHO to do because of the potential conflict of interest with industry partners, but nevertheless they're of course an extremely important part of this. So we'll see how this goes as we go forward. And I never miss the opportunity to put in that shameless plug for our society, the American Society of Tropical Medicine and Hygiene. If you're interested in these sorts of issues, we'd be happy to have you join and join us at our next meeting in Chicago. I'll stop there. Thank you.
Okay, well, thanks to all the speakers. What we'd like to do now, I'm just looking at the time. I'd like to take about 20 minutes or so for questions and discussion from the members of this last panel. And then in the last 15 minutes, I'll invite those who are still here from the first panel to join Q, so he's not by himself, up here. And just so you're thinking about kind of the thing, what I'd like you to all think about really is, because we can all talk about interesting concepts and things that we feel strongly about, but ultimately, I think the value of these types of events, these types of activities, are some action items. You know, okay, we're not going to basically be the effectors, perhaps. Well, maybe we could be, I suppose. But I'd like you to think about, from your perspective, your experience, you know, what are a couple of action items that, you know, if you were the king of the world or whatever, you could actually make things happen that reflect on this particular topic of equitable scientific collaborations, partnerships, and coordinations. So I think that's how we'll do it. And of course, like before, if people have questions, use the mics, identify yourself, et cetera, et cetera. And I don't know if we have any online questions, but we won't take those just yet. So let me kick it off. And I won't be able to tell for our virtual attendees sort of who's going to answer. So I guess it's like whoever jumps in first. Okay, yeah, I see them. You know, I think Peter Hotez, you know, kind of alluded to this at the outset. You know, a lot of this is about leadership, and it's both scientific leadership and it's also political leadership. It's getting things, making things happen. And we've seen in the context of the pandemic, we've seen a lot of surge efforts, whether it's Operation Warp Speed or other activities around the world. But I guess the real question is, in the context of limited resources, multiple sort of pulls for available funding, et cetera, how does this get sustained? You know, in other words, you know, we get past pandemic and everyone says, yep, we're done. You know, that was bad, but we got through it. And we heard, you know, certainly previously, you know, related to the U.S., you know, we got a lot of science, but we have a very fragmented public health infrastructure. So there are real problems there. And so how do we sustain what we think needs to happen based on the innovations, collaborations, et cetera, that have occurred thus far, you know, even as we try to make it better? So that's, I think that's kind of my big question. And so I'll invite any of our panelists from the last session to maybe jump in, because I think it has different implications, U.S. versus global, as we've heard. So anyone feel free.
From South Africa quickly. So from a South African perspective, the lesson that we learned was the importance of investing in local science and to make sure that the questions we answered were relevant to our country and kind of decolonize science and answer questions that were important for South Africa. The second thing that we learned is the importance of health system resilience. And because our health system was quite fragile, you know, we could not diagnose TB anymore, or we could not retain people on HIV treatments, or we fell off on monitoring people's CD4 count and viral loads. So it's important when you look forward is to make your health system resilient, to absorb a pathogen that's coming on, but to make sure that people who need treatment and chronic care are taken care of. So we have to look at both things to strengthen our health system, and how we do that remains a big question in poor countries, but also to make sure that poor countries invest in science, and that we continue to make sure that we develop and maintain the scientific capability within our countries, and not look forward to a future pathogen, but invest in the science and the diseases that affect us now, because that'll help us pivot to the future. I get worried when we start thinking about, preparing for some kind of future pandemic when we don't address the common problems that cause death and devastation in our countries at the moment. So I'll stop there.
I can jump in then straight to follow, because I think that's great setup. I think there are two things that we need to think about. This. Everyone has said that this isn't a one-off action that's going to solve this. It requires actions from many, many different stakeholders. Now, some of those actions are a step change, right? I think the regulatory example from CEPI earlier is we've seen what can be done by regulators, and we know that basically what needs to be changed. So once that's put in place, that will last. Most other things actually, as Glenda just said, require ongoing investment. They aren't like that. They have to be built in a sustainable way. And I would add just a note of caution. I do see in some of the debates very simplistic solutions being put forward, which might have a short-term impact, but actually there is no plan for sustainability in some of them. And so let me maybe be slightly controversial and throw out two that I think are short-term sort of actions that have definite longer-term risks attached to them. One is the concept of waiving IP during future pandemics. That will, everyone I think agrees, have an impact on the R&D that is needed ahead of time. And whilst we understand very well that some of the pressures behind that, this is one where I think it's vitally important that we have a really long-term plan to make sure that investment does continue. The second one, again, maybe slightly controversial, but there is a lot of money available at the moment to build factories, vaccine factories, medicine factories in places where they don't currently exist. Whilst that is desirable, again, if those factories don't have a market or even don't have products to produce, they will pretty soon become obsolete, and that will again be a big waste. So, from my industry's perspective, just to summarize, we're not opposed to any of the objectives that are trying to be achieved with those proposals, but we believe both of them create real risks, systemic risks, and will potentially undermine the sustainability that's needed for the future system.
Yeah, this is Peter Hotez. I'm partly in agreement. Let me phrase it in a different way, though, and that is, I think one of the mistakes made was this idea that only the multinational pharma companies have the chops to pull this off, and therefore the model is you provide incentive funding for the pharma companies, and eventually the crumbs filter down to the LMICs. And we clearly saw that was a catastrophic failure. There were no mRNA vaccines available. No, none of the vaccines were available for LMICs in the first 2 years of the pandemic. So it's also important not to demonize the pharma companies. They do a lot of important work. They provide a lot of important vaccines for Gavi, a lot of innovation, but the ecosystem needs to be balanced. And balancing means building capacity for the LMIC vaccine producers, and it's multifaceted. First of all, we need, and I agree that just building the factories is not the answer. It's because vaccines are more complicated. They're biologics. How you scale them under quality control, quality assurance, takes years of building human capital. That process needs to start. And it's not only human capital within the vaccine producer, it's human capital in terms of more upstream vaccine science. Not long ago, the head of the African Regional Office of the WHO grabbed me by the arm pre-pandemic and said, we need a Buruli ulcer vaccine. Who's going to make that? It's a disease of regional importance. You're never going to get Merck or Pfizer or GSK to make a Buruli ulcer vaccine, but you could get a vaccine producer in Africa to take that on. But you need academic scientists that know about vaccine science looking at different platforms. So that has to go hand in hand with building the universities around a culture of vaccine science to go along with it. The other big issue is the regulatory capacity. Right now, if you want to get a vaccine approved globally, you either have to go through WHO pre-qualification, which is slow and unwieldy, or you go through one of the stringent regulators, and there's reciprocity. Who are the stringent regulators? Well, it's the usual suspects, right? It's the US FDA, it's Canada, MHRA, the EMA, Japan, Australia. And there's no LMIC national regulatory authority that's afforded stringent status. And maybe that's where we need to focus that as well, because what happens is you get the LMICs acting as supplicants or Jude the Obscure, sort of looking on the outside in with their nose pressed up against the window, hoping against hope somebody validates them and approves them. So obviously India is the biggest, Brazil's up there as well. Building that capacity to afford them stringent regulatory status, I think will also help quite a bit. Finally, I think we have to be careful about mRNA. It turns out that pretty much anything that delivered the spike protein to the immune system worked, whether it was our recombinant protein vaccine, whether it was mRNA, whether it was adenovirus, whether it was particle. And I don't know that it was necessarily the best test of mRNA. Whether mRNA will stand up so well against more complicated vaccine targets. So the bottom line is we have to keep multiple technologies in play because you never know what's going to work. I mean, if you had asked me at the start of this pandemic what was going to be the winner, if there was a winner, and you said, Ixnay, Peter, I'm voting for your vaccine, I would have said, well, that Ebola VSV technology that came out of Merck looked pretty good. A single dose, effective vaccine against Ebola, known virus pathogen. That's the one I might have voted for. But I think what happened was when you put the spike protein gene into it, it didn't replicate well and turned out not to go. As opposed to mRNA, I would have said, well, we've had nucleic acid vaccines for a couple of decades. They really haven't panned out. And then mRNA did much better than we predicted. But the bottom line is you don't know for the next pathogen which is going to be important. So I think it's also really important we don't all go running. Everyone's talking about building mRNA capacity in Africa and South Asia, and sure, but I would say alongside all the other technologies as well.
Umair Shah, Secretary of Health of the great state of Washington. Peter, it's great to see you virtually. A colleague and friend for so many years. Thank you for continuing to do the great work.
Great to see you.
I wanted to ask a question of all of you. First of all, thank you for this panel. The question is really around transnational health system strengthening and really this approach that we ultimately have so much in common when it comes to themes of taking science to practice, science to populations. And yet, Peter, I think you and others have really articulated this real misinformation, disinformation that is now starting to get in the way of real success in being able to do that. Do you have strategies that would help us bring the global domestic worlds together that really allows us to raise up, elevate, if you will, the transnational health system strengthening that allows us to really approach this across borders, across lines that really allow us to be successful as as a globe. And
Well,
that
I'll just talk about the disinformation part and then leave it to the others for the more substantive aspect. For the disinformation, I think the problem is we refuse to talk about it. I mean, the UN agencies refer to it as the infodemic. We still call it misinformation, disinformation, as though there was some random junk that somehow appears on the internet. And it doesn't do justice to the victims of this, who 200,000 plus Americans have lost their lives. This isn't random. This isn't disinformation or misinformation. It's targeted anti-science aggression by a political entity that did it for authoritarian and political gain. And it's a killer. I mean, anti-vaccine activism now killed more Americans last year than gun violence, than nuclear proliferation, and cyber attacks, than global terrorism, all the things that we build infrastructure as to combat a dangerous societal force. And yet we don't frame it that way. And I think we now have to recognize that this is a new reality and it's now gone global. And I do think it's going to have a big impact. You know, for instance, when we introduced the malaria vaccine, I mean, we're already starting to see that same kind of US style anti-vaccine rhetoric used against the introduction of both the RTSS and the Matrix M R21 malaria vaccine. And we're going to see it for others as well. So recognizing that this is a deadly force and it needs to be contained, and exactly how we do it, I can't answer because it's gone out beyond the health sector. It's now in the political realm. And I think this needs to be addressed at a future G7 or preferably G20 summit.
I can maybe add a few comments on the transnational nature of how we bring countries together or don't bring countries together. I think there's really a very changing architecture for outbreak response over the last few years that is kind of gone against the colonial grain that had been set up, and people in high-income countries kind of respond, and low-income countries are the recipients of aid. And the outbreaks that I've been in, COVID and others, there's been a drastic change in that, and a real sense of ownership that comes from countries and a sense of sovereignty in making the decisions. I think there's still an uncomfortable balance of accountability there, and a lot of questions about how do we reframe or recast IHR, for example, and how do we put teeth to that accountability that allows countries to interact in a productive way, but also with accountability and when bad things happen. And it's an uncomfortable transition for many that are in that right now, but I think it's a transition ultimately that's good, that needs to occur, and we just need to kind of see that through.
Maybe I could just chime in here. I think I would like to emphasize the idea that this COVID pandemic really emphasized and taught the world that in an emergency situation, you really can't exclusively depend on certain high-income countries. Every country will be self-interested because it's an emergency. And I think in the future, it'll be the same. So you really have to distribute that capability, that research capability, that manufacturing capability. You can't depend on something coming in, I think. Now, that may not necessarily need to be done per country. It may be a regional approach that needs to be done, but certainly it has to be distributed. And the other thing that I would say is that when we're talking about global efforts, it's really important to find out what is in the interest of the country, what they think is in their interest, not presuming what you think is in their interest. And I think that still happens a lot, and I think that will be something that gradually will change, but it is something that I think in high-income countries, there's a tendency just to gravitate towards that. I think in a couple of years, I think that same tendency will occur. So what will happen, I believe, is that there will be some resistance in that way of thinking from all the other countries based on the experience that they've just had, for example. So I think when trying to develop these kind of global efforts, that very active effort to find out what is in the interest of those countries, what they think is in their interest is going to be really critical.
I think it's kind of an issue of there are different best practices, and they have to be tailored to the context of countries and those realities. Just like there's differential, you know, Peter, to your point about, I'll just use the misinformation, disinformation terminology, but you know, how that is viewed and propagated and in, say, the US versus sub-Saharan Africa, Southeast Asia, or somewhere else, the drivers may not always be the same. And so the approach to try to, I think, address those is probably has to be tailored as well. Would you agree?
Yeah, absolutely. There are definitely national differences, regional differences, and Heidi Larson at the London School has done an excellent job, you know, cataloging those and describing how it differs. The point that I was making, though, is there's been a change now in that now we're starting to see the export of this US style of anti-vaccine activism and the similar kind of rhetoric and similar use of language around health freedom, medical freedom that is now contaminating the LMICs. Whereas in the past, we didn't really see that. And that's the new danger that I'm concerned about. And by the way, you're also seeing it adopted by other authoritarian regimes. You're starting to see also that language picked up. Well, Bolsonaro's gone now, but when he was in the head of Brazil, you saw that. You saw it in Orbán's Hungary. You started to see picked up by other regimes as well.
Okay, I wonder if I could invite the rest of the panel members from earlier, whoever's still here, come on up, and we can kind of have a lightning round, so to speak, of some action items that I think would be key for this discussion.